Good morning, everyone. Today I'm going to discuss on Olmutinib, which has been briefly addressed in the last talk as well. Not briefly, quite vastly actually, because this drug actually is a T790M mutation positive non-small cell lung cancer targeted agent, and after failure of first line therapy, it has been touted that almost 60% of the cases who progress on first line EGFR are T790M positive. That is some data to it. So there was a search for T790M mutation active drugs, and that has led to evaluation of a lot of drugs like Olmutinib, Osimertinib, which actually won the battle, Rosilatinib, Naquatinib, and Nazaritinib. These all were designed. The drugs which saw the light of the day were obviously Osimertinib, we know on the hindsight, but why are we discussing Olmutinib here? Because though this drug development is stalled, as has been told by the previous speaker, but still that data, let's say phase 2 data which I am going to present right now, is quite encouraging actually, and it leads to a lot of questions. So this is a multi-center, single-arm, open-label, global phase 2 study evaluating the efficacy, safety, and pharmacokinetics of Olmutinib in patients with T790M mutation positive NSCLC after failing an EGFR TKI. Patients were enrolled for 1 year from 2015 to 16, and the study was conducted in 68 sites in 9 countries. Inclusion criteria are pretty standard. Patient required to be an EGFR positive patient who progressed on a TKI. Prior chemotherapy was allowed, and even the brain metastasis was allowed. ECOG 0-1, life expectancy of more than 3, and centrally confirmed T790M mutation positive. Exclusion of obviously previously treated patients, even with afatinib and cetuximab, they were excluded here. Spinal cord compression, history of any other malignancy in past 5 years, and standard interstitial lung disease and radiation pneumonitis were also excluded. Though the endpoints here was ORR, mind you, this is a phase 2 study, ORR with a confirmed best overall response assessed every 6 weeks. Actually it was done till the PD every 6 weeks after administration of the drug. Secondary endpoints, they looked at various things like disease control rate, duration of objective response, overall survival, tumor shrinkage, PFS, and top of the notch safety. So this is in brief the study design, and this is the dosing which they used upfront: 800 mg once daily dosing continuously in 21-day cycles. And the primary endpoint, as I told earlier, was ORR. Baseline characteristics, as you can see, women were 61%, performance status ECOG 1 was 72%. They had around 30% of the smokers as well. Patient with brain metastasis comprised of 50%. Now that's very impressive, because that actually gives you a lot of insight in the intracranial activity of this drug. EGFR mutation very well spread across. T790, obviously it was inclusion criteria, so it has to be 100%. And previous lines of systemic therapy, as you can see, up to 4 lines of systemic therapies were also allowed here. So in short, these are the results. As you can see, that overall response rate, which is centrally confirmed, was 46.3%. Now, we are not in a battle here with Osimertinib. Obviously, Osimertinib has beaten this drug hands down in both safety as well as efficacy. But still, an overall response rate in second line of T790M positive patient of 46% cannot be ignored. Partial responses, stable disease. The disease control rate is again 86.4%. This is across the brain metastasis. Even those patients who had brain metastasis, they responded as good as the patient who never had brain metastasis. So this is intracranial active drug. This actually, we struggle with patients when they develop brain metastasis in EGFR positive patient. This actually has got intracranial activity. Similar has been when dose reduction was done. Though dose reduction was done, there was a lot of toxicity was reduced actually, but the efficacy was not that hampered. As you can see here, the overall response rate again here is around 40 to 50%, even up to the dose reduction of 400 mg per day, which is actually the half from what they started. And overall efficacy, again, according to the number of previous lines of therapy, was again not very different. Median duration of response as well as PFS was not very different between first and the further lines of therapies. This is just standard survival probability analysis curves where you can see PFS of 9.7 months and OS of around 19 months. Obviously, it's very premature to comment on OS and PFS on a phase 2 data with a handful of patients, but still, if you compare it with osimertinib, osimertinib also boasts in this setting, mind you, in the second line setting of T790 positive patients, osimertinib boasts of the similar numbers. Adverse events, yeah, here is where this drug is very challenging, and as you can see, almost all the patients had adverse events, drug related adverse events, some very serious, grade 3 and more, as you can see, is 48.2%. That's quite a big number, and that becomes unacceptable in second line to third line because it compromises the quality of life. Patients actually, one patient even died of Stevens-Johnson syndrome, TEN, and that's why this drug should be handled with care. And simultaneously with the development and very impressive data of osimertinib, this drug development took a back seat, and ultimately it is stalled as of now. The incidence of TAs, according to dose reduction, as you can see, after dose reduction, there is a very, very good improvement in the side effect profile. So, in conclusion, this is a largest phase 2 global study for Olmutinib. Olmutinib 600 to 800 mg once daily has meaningful clinical activity and largely predictable safety profile. It's not a good safety profile, but it is predictable. So with dose reduction, we can obviously manage it somehow. Early outcomes are promising, but safety and risk-benefit concerns are there. So it's anyone's call. Obviously, osimertinib is a much more refined and a better drug, but this drug should be investigated, in my personal opinion, should be investigated more in certain aspects, because a lot of things are there, as the previous speaker told, about the resistant mutations. Thank you. Thank you.